Good morning, everybody. Thank you so much for joining us today. I'm here with Marjorie Arca, Meghan, Arnold, and Samir Gadepalli. I'm going to have each one of you guys go around and talk a little bit more in just a minute about locally what's happening in your hospital in terms of taking care of sick adults with COVID. I think many of us as pediatric surgeons are very active in critical care of babies and children, but it's been a while since we've taken care of any sick adults with adult types of comorbidities as well. So as many of us in our local environments are preparing to do this, we really wanted to hear from you. And there's a really helpful slide deck that has been put together and posted on the APSA website, which you can refer to if you're watching this video, but we just love to start with just a conversation. So why don't we start by going around and doing a little bit of an introduction, providing some local context. Why don't we start with Marge?
Hi, good morning. I'm Marjorie Arca. Actually, I'm currently in upstate New York, so it's not New York or New York City. And our, actually, we did a very early social distancing. I think it was the second week of March. On a Sunday, we did quite a bit of social distancing and canceled elective cases, elective clinics. So our community COVID surge has not been bad. We have done a lot of delegating of the ICUs. So for instance, our surgical ICUs have been now dedicated to medical ICUs, our surgical, so cardiac, neurosurgery, trauma burn, and the surgical ICUs have relocated to what would be our pre-anesthetic or preoperative area, and also our PACU. Our acute emergency adult cases are done in one of our affiliate hospitals. So if you have a small bowel obstruction, you go there instead of coming here. All of the sick COVID patients come to the University of Rochester. The Children's Hospital is a tower of the adult ICU. We've elected to keep all the children, thankfully, in our neck of the woods, unlike, say, places like Montreal. We do not have any COVID positive pediatric patients in hospital at this point. So the way that we participate in the adult care is actually determined systematically. We're the line people, the line and procedures people. And so what they've done is they've created a schedule by which surgeons, there's a schedule of surgeons that come for whenever they need procedures. They just have us come in and help at that point. Now that's like phase 2. Phase 3 is obviously different, but we're currently at phase 2, thankfully, at this point.
Okay. Thanks, Marge. So at this point, you are involved in the adult patients, but mainly just for procedures, not in primarily managing their critical care. Okay.
Yes.
Meghan, do you want to tell us a little bit what's going on in Michigan?
Sure. So my name is Meghan Arnold. I'm one of the pediatric surgeons and critical care physicians at the University of Michigan. And despite doing some moderate social distancing fairly early within the state, we have seen our COVID surge and are sort of right in the middle of it. And primarily what we've seen at the University of Michigan is a drastic influx of patients from the Detroit area, which is being very heavily hit with very sick COVID patients. So within the University of Michigan, we have expanded our ICU capacity dramatically. So typically we have about 100 ICU beds. Our goal at the end of this is to be able to support as many as 270. So we have expanded all of our current ICUs, both our medical as well as all of our surgical and affiliated surgical ICUs have become now full, or essentially full COVID units. And then in addition, what's really ramped up over the last 2 to 3 weeks is that we've converted an entire floor now of the Children's Hospital what used to be 64 pediatric single bed rooms now has the capacity to be 100 COVID ICU beds. One of those units is at full capacity of right around 50 patients. And the last one, which is going to be primarily staffed by the pediatric critical care medicine and then the pediatric surgery teams, just opened up this week. Currently has a census of 5 patients. The plan is to get towards sort of 10 to 15 patients by the end of this week. So in that unit, we as the pediatric surgeons are the attendings providing the care. And then I've spent some time in the sister unit with the adult providers, which is primarily the anesthesiologists, who are being the bedside attendings of those patients.
Okay. So it sounds like a little bit more further along compared to in upstate New York, where you're actually already involved in taking care of these patients.
Mm-hmm.
Samir, you're also in Michigan. Do you want to give a little bit more context in terms of how was it decided how that unit, especially the one that's in the pediatric hospital, was going to be staffed? What combination of, pediatric critical care, pediatric anesthesia, pediatric surgery? Are there any adult providers in the midst? How did you guys kind of train and prepare for this?
Yeah, so Samir Gadepalli, also a pediatric surgeon and an intensivist at Michigan, working with Meghan Arnold. So we actually, both of us have been covering the adult ICUs this week, and in the 2 units that Dr. Arnold mentioned, she has been in the original regional isolation unit that has 50 beds, and then the second unit just opened up this week, and I've been in the new unit. The new unit would be staffed with pediatric intensive care as well as pediatric surgery. Our anesthesiologists have been the airway team for all of the ICUs because, as you can imagine, intubation, extubation are aerosol generating procedures. And so it takes a fair amount of resources and effort to do those. And so they've been available primarily for intubations, but we'll probably talk more about this, but there's definitely differences in terms of adults and extubation rates and reintubation rates. In pediatrics, we've tended to be more conservative about extubations and how parents handle failure of extubation with reintubation is very different than in a COVID unit where unfortunately there's actually no other family members, and there's also a need for ventilators to be freed up. And basically in the adults, we've been very aggressive about getting them off ventilators. And in fact, we've seen almost like a 20% reintubation rate, which means 80% have been successfully extubated in a fairly aggressive manner, where they'll come off to like a high flow of like 50 liters, 50, 60% FiO2. The trade-off is like, PPE use and exposure of healthcare workers in the setting of reintubation. And so it's definitely carefully planned, but we're being fairly aggressive about it. So in terms of training for the model of care, all of us have kind of spent some time on the adult unit that is being staffed by pulmonary critical care medicine, CCMU physicians, as well as anesthesia adult. Now that the unit has opened up, it's primarily been staffed by pediatric providers. But now when I say providers, I don't mean just like the attending physicians that you see here, but also we have our PAs being deployed there, NNPs from the NPs from the pediatric medicine side. We have pediatric residents, pediatric hospitalists. We have some of our surgical residents in the adult SICU now. And so we basically focused all of our care in helping develop the ICUs.
Okay, thank you for that. So you mentioned that you had spent some time with some of the adult providers to prepare. Are there a mix of adult and pediatric providers in the unit that's been put up in the pediatric hospital, or is it now solely staffed by the pediatric?
So as of right now, it's solely staffed by the pediatric providers.
And the
So
PAs and the extended care providers you mentioned, those are pediatric trained as well. Are they from the ICU, or are they from the surgical teams? Is it a combination?
combination. So, you know, for example, the last 2 nights I've been on with pediatric hospitalists, and they don't have any ICU experience, but they've been able to serve as frontline providers, gathering data, making decisions, so forth, with supervision from ICU physician like myself.
So a couple weeks ago, we had Dr. Stilianos on from Columbia, and he had shared a kind of a pyramid structure for the hierarchy of how the care is managed in the ICU. Maybe one of you guys can talk a little bit more about that. You mentioned, Samir, that you are supervising people like hospitalists or other frontline providers. How does it work compared to like the normal way that an ICU would be staffed in terms of how many different patients care the kind of top of the pyramid would be supervising?
All the units had very similar structures. So I'll talk about the new unit that we opened up has basically 4 providers as frontline providers, each of which will eventually have up to 12 patients on their teams. So there's 4 teams, and each of those teams have either residents or advanced practice providers as frontline, being hierarchically supervised by a fellow and then a faculty. Dr. Arnold, do you want to talk about the RICU?
Sure. So the RICU is the sort of sister unit. And in that side, again, 4 teams, 2 led by pulmonary, 2 led by either surgery or anesthesia. Each one usually has between 2 and 3 either residents or APPs doing the minute-to-minute management. Usually have 1 fellow divided between the 2 teams, and then each team is led by a faculty member. So a core group of about 4 people. Like Samir has described, that the one unit has been up and running for about 3 weeks, and then the sister unit is just opening, trying to keep the same model. The big difference between the 2 is that in the newest unit is primarily being staffed by pediatric providers, but it's right next door to the main, the RICU, the regional isolation unit. And so there's been a lot of sort of just crosstalk between the 2. I was up there yesterday, and the peds critical care medicine attending came over and just sort of clarified some questions. So there's, I think, one of the most amazing things that has come out of this that I hope lasts long term is the kind of can-do attitude that everybody has, and the collaboration and camaraderie that has been generated among people who have never worked together. You know, we have, you know, medical ICU nurses working with anesthesiologists, working with pediatric providers. I mean, the fact that pediatric hospitalists are helping to staff, you know, an ICU of adult exceedingly critically ill patients, I think just sort of speaks to the all hands on deck attitude, and the fact that people have really stepped up to take care of patients that they're not used to taking care of, but with an attitude that, you know, with the appropriate help around them, that they can do it. And I think we, as pediatric surgeons, really have kind of a unique perspective and ability to help, because we did spend so much of our training taking care of critically ill adults. And while we don't, you know, take care of them as much anymore, that we can kind of bridge that gap between the pediatric providers and the adult anesthesiologist and surgical providers. So I think we have a really unique perspective and ability to really step in and fill this need, which right now in the state of Michigan is critical. And what we've seen is that what we are doing is we are offloading the hospitals around Detroit, which are just being absolutely saturated with some of the sickest patients that I have ever taken care of.
May I ask both of you, Samir and Meghan, because we're having a very active discussion around this kind of within the state. What's your decision-making process with regards to somebody who may need ECMO at this particular point?
Mhm. Yeah, we have, so the sickest patients and the ones who might be ECMO candidates are still going to our main surgical ICU in the adult hospital, which is sort of the pathway that they would have always followed. The last time I checked, which was a couple of days ago, I think we had only cannulated 2 people.
Okay.
I think maybe a total of 3 people have been cannulated. The first one was an ECPR. So we're keeping ECMO on the table, but I think it has not been utilized very much. I think what we have seen in our patients, and obviously it may be a little bit different across the country, is that the age range of patients that we're seeing is anywhere from the high 20s up to, I think we have a 90-year-old in the RICU right now. But particularly the younger patients can have significant comorbidities. Morbid obesity is sort of common across the board. And we have younger patients coming in very, very sick with significant comorbidities and are being deemed fairly early not to be good ECMO candidates. So we have not used as much ECMO as I thought that we were going to just a handful of cases at this point.
Right, because in New York, because of the density of the patients in New York City, it's become a statewide discussion. And the data from China did not support the use of ECMO. But then I think there was some thought that since I believe the Chinese data primarily looked at VV ECMO, thinking that this is just like ARDS of the H1N1 kind of flavor, but it's not, because of the myocarditis and the myocardial dysfunction that occurs. And so the question, that we would have is, in a young patient, what is the, number of days that they've been sick? Because from what I hear, day 14 or so becomes kind of it's kind of like you're stranded on, life or death sort of thing. And it's usually you're gonna die after day 14 of intensive support. And whether or not, before then, young person, not a lot of comorbidities, VA ECMO would be offered. And I didn't know if there was a central, kind of decision-making process, because we're kind of grappling with that issue at this point as we prepare for our surge.
Yeah, I've not been as much a part of the ECMO conversations. You're right. They're sort of, I feel like there are kind of 2 populations of patients, and obviously we're only seeing the ones in the ICU. But certainly there's that sort of period of time, day 4 to 10, 5 to 10, where they seem to sort of be doing okay, and then they kind of crash, and they crash really hard, and they need to go on really significant vent support, tend to have pretty significant hemodynamic issues, acute renal failure. What's interesting, what we're seeing is a lot of thrombosis and thrombotic complications, and patients who, as soon as they get intubated and we go to put in lines, and they've already got clot in their IJ, and
Wow.
never having had any instrumentation. So we're empirically putting almost all of our patients on heparin drips, with also some thought from some of the H1N1 experience that we had of just thrombi within the lung parenchyma as well, that was seen on the autopsies. And so we've been really aggressively anticoagulating a lot of our patients. I wonder if ECMO would be a little bit more difficult too, with all of this concern for being so pro-thrombotic. I don't know, Samir, if you have any thoughts about the ECMO experience.
Yeah, so overall, the ECMO experience that's been published has been pretty poor. It's only about like a 15% survival rate. We have a standardized process around like ECMO evaluation and having them being sent to the surgical ICU right now. But like Dr. Arnold said, we haven't seen a lot of patients go that route. We have found that like all of these patients are very different than any other ARDS that I've seen. They are profoundly hypoxic. very high PEEPs. Proning works great. Early proning, even if they're not even intubated yet, still works, very beneficial. I don't really know the pathophysiology of this, but it almost acts like they have PEs, and they respond to FiO2. But in order to keep their FiO2 below 60% or below 50%, we've been basically using the ARTSNet protocol and keeping them on high PEEPs, low tidal volumes, and all of them have been responsive, but it's like they're on the ventilator for 3 weeks and on very high PEEPs and very difficult to wean that PEEP. Each like 2 degree change in PEEP, like going from like, say, I don't know, 18 to 16, all of a sudden they de-recruit, and then you have to re-recruit them, put them on higher PEEP, and it takes them like a day to recover. Even when they're about to get close to extubation, and you do a pressure support trial, we do spontaneous breathing trials to see how they're doing. If they do poorly, it takes them a day, like you just skip the next day and then retry them the day after because it's taken a while to come back. So in terms of ECMO, I agree with you. I don't know if VV would be the way to go or not, because it could be microthrombi in the lung. At the same time, like I would probably start with that rather than trying to do VA in this population. The other thing is though we've had a lot of success getting people extubated and through the process, we've also seen quite a few of patients who've kind of gone the palliative route. And what you find is that it's like, if you're 80 years old, multiple comorbidities, and then you are thinking, gosh, this is not improving. As soon as we've had discussions with families, they've kind of tended towards the route of, listen, I'm not sure ECMO is going to be the way to go. So that has something to do with it as well.
So I wanted to ask you guys a little, just stepping back from the ECMO discussion for a minute, just to kind of just go way back and think about kind of the nuts and bolts of a typical case. And you've mentioned a little bit of that, in terms of like this happens at day 14, this happens days 5 to 10. But if you guys can think about the patterns you've been seeing, and first of all, like what are the thresholds to go to the ICU? You mentioned, Samir, about intubation and trying to be aggressive at extubating. The counter argument I've heard to that is each time you do an intubation, it's another aerosolizing procedure and more risks. And then the risk of being on high flow, and is that generating aerosols? So a little bit also about what you're doing for PPE in all these instances, and kind of balancing those different risks, and really just kind of taking us through the typical clinical course.
Yeah, so we've tried to standardize a lot of the process around the units. I mean, it's still vastly different if you're on the CCMU team versus anesthesia team versus the pediatric team, but we've tried to do a pretty good job of like, this is our anticoagulation algorithm, who's going to be on heparin drips, how we're going to transition, what values we're going to follow. We typically have been following anti-10As, what drugs we're using for sedation. We've tried to avoid benzos. There's a huge amount of delirium associated with it. There is a ARDS algorithm that we've then started to use amongst the units to try to have some consistency. Because as you can imagine, we now have patients in the surgical ICU, the RICU, the regional isolation unit, the sister unit that we just formed now that's going to have up to another 50 beds. The PACU has been converted to an ICU on the adult side. We also have beds in a step-down unit that's become a full ICU unit, as well as 2 regular hospital units that would become step-down units. And so if you have completely different processes in each of these areas, it's going to be a nightmare. And so we've had a daily phone call between all of the ICU leadership in terms of like what the processes are going to be, and then, assigned a couple of individuals. There's in terms of PPE, other things to think about are like a lot of these procedures use ultrasound. And so like, how do you then cover the ultrasound, not just the probe, but the whole machine, so that you can use it from patient to patient. We've also double roomed a lot of patients. And so how do you then, say you're going to check C. diff on one patient and the other one is not being checked, then like, how do you then manage that? So there's been a lot of stuff that we've learned kind of along the way in terms of how to do it. In terms of daily activities, so we've tried to limit the number of providers that do the exam. So we usually just have one provider going in to do the exam. And ideally, that same provider has both of those patients in that room. And so that we've limited number of exams. Any patient that recently got admitted or transferred, I've been the one in the unit to like walk in and see them just so that I can get to know what's happening. If they have wounds, or like we've had somebody with a sacral decubitus, I wanted to examine it and take a look at it, being the surgical member of our team. But you know, you don't want to have everybody get exposed multiple times. In terms of PPE, we've also done a lot of conservation where we take the N95 mask and we've been decontaminating them. And so at the end of your shift, you would then put it in a brown bag with your everything labeled, and you put it in like a main area, and that gets decontaminated. So when you come back for another shift, then you can pick that up and reuse it. There's also a face shield that we use on top of the N95 mask to prevent the N95 from getting any kind of droplets over it, to try to increase the length of use. That face shield then gets wiped down after each visit with one of the bleach wipes. What else? Megan, do you have?
Yeah, I think a couple of key points that he mentioned. First is really trying to limit who's in the room. So while these are ICU patients who require a lot of intensive care, we're trying really hard to limit blood draws as much as we can, who needs to be in the room. And if you decide that you want something done, you know, you want labs at noon, but then maybe you want something at 4, you sort of pick one of those times and get everything done at the same time. Again, trying to limit the number of physicians who go in the room and examine patients. So at most sort of one person, maybe once a day, unless there's an acute change. You know, really it's the nurses and the RTs who are doing 95% of the bedside care. And we have, you know, in some ways the luxury and the privilege to not have to go in quite as much. But I think batching care, batching labs, we are not able to get a lot of bedside studies done. It's sort of interesting which departments are willing to do it and which aren't. Our vascular access nurses have been amazing. So they're coming up and putting PICC lines in if we need them. We had a bedside IVC filter placed yesterday by interventional radiology in one of our patients who has lower extremity DVTs and can't be anticoagulated. But what's been really hard to get are DVU studies to actually document clot, as well as transthoracic echocardiography. So we've been doing our own bedside TTEs. So it's sort of interesting how differently you begin to practice and how thoughtful we're trying to be about how many times we're going in the room and what needs to be done at different times. In terms of some of the sort of nuts and bolts about taking care of these patients, so by the time they come to us, they're either on significant high flow support, which we have been able to do because the RICU, our regional isolation unit, is a fully negative pressure unit. And then we've added HEPA filters and created a lot of negative pressure rooms. So I know the early recommendation, and in the slide deck, people will see that the goal was to avoid high flow nasal cannula. We are actually using a fair amount of high flow nasal cannula, partly because some of the data suggests that if you do require intubation, your mortality is exceedingly high. So whereas I think the initial recommendation was intubate early and avoid high flow, now we're trying to find a happy medium between that, which is if you can manage on high flow, keep them on high flow, obviously with some increased risk in terms of is it aerosolizing. We've been lucky here that we're doing okay on PPE with some attempts to try and conserve it, as Dr. Gadepalli mentioned, in terms of reprocessing N95s. But we have enough gowns, we have enough face shields, we have a fair number of PAPRs. So PPE has not been an issue at our institution, thankfully, at this point. but we are trying to avoid intubation if we can. We're proning patients before they get intubated. There's been some good anecdotal evidence that even proning people before they're intubated can potentially keep people from having to be intubated. As he mentioned, once they're intubated, I've been going really quickly to high PEEP, 18 to 20. I agree with him. Very small changes, really trying to work on getting the FiO2 down before I start weaning PEEP. And that small changes and changes sort of once a day, almost like how we wean vents on our CDH babies, which we're really conservative with, is kind of the same thing here, is just very, very slow moves. And once I get the FiO2 down to about 40 or 50, I start going down on my FiO2 by 5s instead of by 10s. But they're exceedingly hypoxic, tend not to have as many issues with ventilation, but very PEEP responsive in general. We've used paralysis a fair amount. The sort of 3 keywords I gave to the rest of our pediatric surgery group here was PEEP, proning, and paralysis. And early use of proning and paralysis has rescued a couple of our very hypoxic patients. And we use a fair amount of proning at Michigan anyway, so the nurses are fairly familiar with it. But obviously, you have to take a lot of things into consideration when you're thinking about proning patients, and making sure that the nurses and the RTs feel comfortable, making sure that you have enough people to do it. And again, so it's a balancing act, right? Because you probably need 4 to 5 people in the room to safely prone a patient. And obviously there's the concern of inadvertent extubation. We've had lines pulled out during proning. So it's certainly not something to be taken lightly, but we've had some good success with some of our more severely ill patients with proning, and we tend to do 16 hours at a time. So that's something that has been beneficial.
Yeah. We also group the line placements. So as soon as they arrive, they get all their lines done at the same time. So they get a arterial line, a triple lumen central line, or a PICC line. But typically we've been using the left IJ to keep the right preserved for dialysis access if needed for CRT or intermittent hemo. And then they all get Foley catheters so that you don't have to change or go in there frequently to change them with the known risk of UTIs. And then they all get Dobhoff tubes for NGs for feeds, and they get on goal feeds very quickly. And many of them have been on like Nutrin 1.5. So the volume has been lower to try to make up the calories. And in terms of sedation, we've been trying to avoid benzos. So many of them have been on dexmedetomidine as well as propofol. And the propofol gives you a fair amount of calories. And so the total volume of calories for their feeds drops off significantly. And then every one of them has that's been intubated has been on restraints because they don't want inadvertent extubation. So it's been kind of challenging to kind of manage that and make sure that they have their restraints on, they're properly secured, that it isn't like, you know, done harmfully. And then some of them have required like interpreters, and so that's also hard to like do the conversation. And so there's a phone that's dedicated for the room where it's like for internal use only, and that has like FaceTime option on there, and it has like a call option on there. And so we've just been using that to like have the families converse with the patient by FaceTime. And so they might be intubated, but then they're conversing with their family because primarily it's bad lung disease with some kidney dysfunction, heart dysfunction secondarily. But trying to bundle all your procedures and lines up front, I think, is very useful because once they're in, then you're good, and you can limit the number of times you have to go in there. The whole goal has been to like decrease healthcare worker exposure, and so there's an actual safety monitor that's in the hallway that is constantly roaming around and looking to make sure you're donning and doffing okay. My first night on, I watched the video, I looked at the pictures, but I sucked at it. And the safety monitor like just pulled me aside and was like, okay, we're gonna redo this again. I'm gonna have you practice and like until I got it right. And then when I walked out of the room, just stood there and watched me undo everything properly and was like, okay, good. Now, the next one you're gonna do without me standing over you. And like, it was like, it took me a while to get the hang of it. And it's like, it sounds dumb, but like I've seen the video like, I don't know, 20 times. And I still feel like until you do it a few times and know how to do a good job of protecting yourself, it's hard to do. And everyone looks at, there's always a buddy in terms of like making sure if the monitor is not there. So the monitor wasn't there in the middle of the night. And so you buddy up with someone so that they're watching you donning and doffing as you go in and out of the rooms. So you protect each other around it. As soon as you come out of the room, you go back to a regular standard face mask. And so face masks are given out as soon as you walk through the door for the whole hospital. And you just keep it for the day. And at the end of the day, you turn it in and wash your hands. The University of Michigan Pharmacy made up own bottles of like Purell. Basically, it's isopropyl alcohol, like 75%. And we've just been using that and just recycling those bottles to try to preserve a lot of it.
Yeah, we have a microbrewery make it for us just because they can make just about anything. I'm actually interested in the heparin that you guys are giving. Are you doing that like when they're still mild? Is it unfractionated heparin or Lovenox that you would use?
So we are using a lot of heparin drips. So if we document clot when we're going to put their lines in, then we have two different nomograms within the institution. One is our DVT-PE nomogram following 10As with a goal of 0.3 to 0.7. The other, so that's one population that's been getting the heparin drip. The other population is we're checking D-dimers on all of these patients. And on some of them, they're coming in with D-dimers in the double digits. Those patients were empirically putting on heparin drip, but at our acute coronary syndrome nomogram with a goal 10A of 0.2 to 0.5. Okay. And then if we've been monitoring the D-dimers daily for the first couple of days, and if they start going up, then we put them on the ACS nomogram as well. So it's sort of three different populations: documented clot, those whose D-dimer starts high, or those whose D-dimer starts increasing. We put on a heparin drip. Otherwise, we are trying to use Lovenox for prophylaxis, but the rate of acute kidney injury and acute renal failure is quite high, which makes it a little bit limited, either because we're causing the AKR or they're coming in. We've been pretty aggressive with CRRT in our patients, but it's interesting because when you actually sort of look back, a lot of these patients are coming in having been quite ill at home for the better part of a week or so, often with diarrhea, not eating. And so they're coming in with a mild to moderate AKI. I actually, in the past 4 days, only admitted one patient. Otherwise, all my other patients were pretty stable. And he came in and we spent sort of the first 24, 36 hours very gently hydrating him, using a lot of albumin to try and keep the volume low, and then sort of stabilized him out. I think his FiO2 only went as high as about 70, but his PEEP was as high as 20. And then after about 48 hours, we've started some very gentle diuresis just with Lasix and Lasix drip. And his creatinine is still normal. But I think of the 12 patients that I've been taking care of, at one point I had 5 on CRRT. And I think some of it is that they're coming in dry. I think we're also trying to keep them certainly on the drier side. But those are kind of, a couple of pearls in terms of the heparin drip. We've been really aggressive with starting heparin, partly because we were clotting off CRRT machines left and right. And seems like every time we've looked for a clot, we found it. So, and also part of me wonders if some of this sort of sudden cardiac death that we're seeing in these patients is actually from PE. Right. So we have probably half of our patients, half to 3/4 of our patients are on heparin drips.
Meghan and Samir, I'd like to talk a little bit more. Meghan, you started to touch on it with the fluid management.
Yeah.
I haven't heard you guys mention pressors much. Are we not seeing, sepsis needing pressors as much? I know you mentioned running them pretty dry,
So,
not even using any maintenance fluids. You just talk a little bit more about that.
Sure. We are, yeah, trying to, there are no maintenance fluids. We're trying to keep drips really to a minimum. So our goal in general has been whatever they're getting for their carrier, which we're trying to limit to 10 cc's an hour, and then their sedation drips is really all the fluid that we're giving them, and then just trying to do very sort of cautious, small boluses, often of 5% albumin. We are seeing in some of the, like I think I mentioned earlier, there really seem to be sort of two groups of patients, and one of them are the ones that we think are having kind of this cytokine storm, and the ones that are being evaluated for the IL-6 inhibitors. And they can come in profoundly hypotensive. We are using norepi as our first line vasopressor, and then vasopressin if we need a second one. And we certainly have some patients who have required pretty significant vasopressor support. Often we'll just keep a little low dose norepi on as we're trying to diurese if we think that they're fluid overloaded. Often some of the patients that are coming from the outside hospitals, which is the majority of our patients, do come fluid overloaded, and we are trying to diurese them pretty aggressively if they're already in acute renal failure, and certainly trying to keep them much more on the drier side. Our initial sedation plan, really coming from the adult side, is propofol and fentanyl. And as Dr. Gadepalli mentioned, because of all of the calories in the propofol, they don't actually need that much tube feed. Some of our patients, their goal tube feed rate is 15 cc's an hour of the Nutrin 1.5. Because of the fluid restriction, we are seeing a lot of hypernatremia. So we're doing some free water, primarily enterally, again, just to try and decrease as much of the IV ins as we can. So for sedation, we're trying propofol, fentanyl. We have started running into a little bit of an issue with some fentanyl shortages here. So this past week, I've been trying to switch over to more enteral. So enteral oxycodone and enteral Ativan, also to try and give a little bit more steady state. But one of the things that there's so many sort of little pearls about how to manage these patients in an ICU. And he mentioned it a little bit. Our protocol had been to do spontaneous breathing trials every morning at 5 o'clock in the morning. Well, in a 50-bed unit with 2 people in each room, it's hard to do that many SBTs. And we were having a lot of unplanned extubations very early in the morning. And we are using much more physical restraints than we typically do. But the big issue is, the patient starts reaching for their ET tube. I mean, it takes the nurse 5 minutes to get appropriate PPE on to go in the room. And in that time, we were having sort of too many extubations. So we're keeping patients more sedated than we would typically. And we're having to be a little bit more thoughtful about who gets SBTs and making sure that we just have the safety mechanisms in place. Communication from outside the room to inside the room is a challenge. In the 2 units in the children's hospital, the door is next to sort of windows, and so dry erase markers and writing on windows to communicate back and forth. We've used the phones already in the rooms, and we've put the phone number on the door. So if you're outside and the nurse is inside, you can actually call and use the phone in the room. We've also gotten a fair number of iPhones, and one stays outside the room, one stays inside the room, so that you can communicate back and forth, so you're not sort of opening the door and yelling in. There's still a fair amount of that going on. But it's all of these sort of little things that you don't necessarily think about until you're in the situation. And then one other thing that I think has been really helpful is, communication with families is always super important. And I think it's even more important now that the families, and I think this is probably true across the country, aren't allowed to be in the hospital and aren't allowed to be at the bedside. And so in a unit of 50 patients of very high acuity, how do you maintain adequate communication with families? And different teams are doing it in different ways. On some of the teams, it's the attending who after rounds just sits down and calls every family to give them an update. On my team this past week, we actually took an anesthesia resident who I think was on the pain rotation, which isn't doing very much. And his sole job was to come in, be there on rounds, and then he sat down and he called every single family and gave them the update. So I think also making a plan for who's going to communicate with families. In our 50-bed unit, we have 3 on-site social workers, and we have our own palliative care team for that unit. They're also going to expand over to the sister unit and cover. So things like, social workers, palliative care, and who's going to be communicating with family and how to do that in an efficient way are also important things to consider, because there's such a higher need for those services than we have on a normal day-to-day basis. And so those are just a couple of the things that the way that we've worked around it. So if that can be helpful to people, so they're not reinventing the wheel and discovering, 2 days in, oh yeah, now we need to figure out who's going to call families, how we're going to communicate in the room, those sorts of things has been really interesting to see the workarounds.
A couple of other things about fluids. One is that how persistent their fevers are is really impressive. Like they'll be in the 102, 103 range for like days, constantly. Like they're getting Tylenol pretty much around the clock, doesn't matter, like just febrile. And so, we do, follow their ferritin levels, their CRPs, their procalcitonin. What we're usually finding is that their procalcitonin are actually on the lower side and their CRPs are elevated and their ferritins are really high. And they can be in the thousands. And so those are the ones that we're kind of looking at using IL-6 inhibitors for. But the fever makes it so that they get really dry. But this is also in a population that's like hypertension, diabetes, potential previous heart disease, potential previous MIs. Some of them have had stents. Some of them have had longer heart transplants. They may have AKI, chronic kidney disease. So like, I know it's been a while for pediatric surgeons for taking care of adults, but there's a list, and some of these medications I haven't heard of because they didn't exist when I took care of adults. And so it's been a learning curve in terms of learning them again and going, oh, that's an anticoagulant that's used at home now. Okay, that's interesting. And like, oh, okay, like before it was just, metoprolol, but now it's like 80 other heart meds that are used for, hypertension management. The endocrine service here has been amazing. They've just taken over the hyperglycemia management on all of the patients. They just said, we're going to own that. And they've taken over like, Lantus, sliding scale insulins, like they just manage the glucose. Like I don't even have to think about it or worry about it. We've tried to limit the number of glucose checks, like because that involves having to go into the bedside. And so typically it's like, getting your blood gas, getting your glucose all at the same time, getting whatever labs you need at the same time. So it's just being very conscious about the time periods around when you actually need those things. We almost never do x-rays, like maybe at admission, and then like a week later you might get another x-ray. Like we get x-rays for like Doppler placements, and then it's done like when they arrive, you just line them up, get your x-ray, and then that's kind of their x-ray for the admission. And you're just trying to limit the number of like trips in. Proning takes work. Like you have to really practice that, just like donning and doffing. Like last night was kind of a slower night for us, and we had people from the adult side, the RICU unit, come over and kind of train some people in how to prone and how to do it. And we just had one of our members serve as like a volunteer to help, like, how to be prone, and it's you're not just going to like be able to do it. You're taking providers who, one, don't work together normally, and two, don't necessarily do some of the same maneuvers. In terms of like lung management, it's been primarily like ARDS type stuff. So like in terms of fluid management, it's all how to keep them dry, but just perfused well enough.
So you mentioned a little bit about following, ferritin, procalcitonin, and that potentially deciding who gets the IL-6 antagonist. Can you talk a little bit more about how you use these kind of inflammatory markers?
Yeah, so like, because they're so persistently febrile, you're always wondering, is there an underlying bacterial infection? And so they do get cultured, but we don't necessarily treat them with empiric antibiotics because most of them have been febrile and is not from bacterial infection. And so we've just kind of followed these markers. So we have an ID consult on pretty much everyone who's COVID positive, and they're kind of helping us make the determination around using IL-6 inhibitors or putting them in a trial for these different medications. So we are using like the protease inhibitors for that have been used for like HIV. We're in trials involved in using those for certain patients. And so ID is aware of the protocols in terms of like who would meet criteria to be in one of these trials. And so we've tried to like have them involved in that conversation from the beginning. And so, but they all get CKs, troponins, CRP, ferritin, D-dimer, procalcitonin, like almost daily, they're getting all of these labs checked and followed. Mostly because you don't necessarily have the ability to get imaging tests that frequently to like follow it otherwise.
Okay. And both of you have touched on this already, but can you give us any other examples of where you've had to you have like an instinct to react in a certain way based on your experience with children, and you have to like check it and reframe your approach?
I think that in some ways has been constant. Yeah, it's just, I don't really know how to describe it. It's, I agree with Samir, it's unlike the ARDS that we're used to. So I think just being super conservative in terms of everything that you do. So very conservative fluid management, very conservative vent management. In terms of vent modes, I think that's probably been one of the biggest questions I've gotten from my colleagues who are concerned about when and if they get deployed to take care of these patients. And what I've noticed is there's no one vent mode that works for each patient. We have some on volume control, we have some on pressure control. One of our units is using almost exclusively bi-level. And I think what I've realized is that the vent mode that works on one patient is not necessarily going to be what works on another patient. And depending on who the attending is or who the respiratory therapist is when the patient comes in, whatever they're most comfortable with is kind of what you try. I would say I probably have half of my patients are on volume control, and we tend to use VC-AC initially and then switch over to a VC-IMV when they're ready to start weaning. We're trying to keep our peak pressures, and plateau pressures ideally less than 30, but we've certainly had some who have needed PEEPs of 20 and have had peak airway pressures certainly higher than I like to see, so sort of 35 and 40 transiently. So trying to switch modes if we can get their PIPs down a little bit. One of the modes that seemed to work yesterday really well was pressure control PSV, which is not one that I've used very often, but was working really well. So I think, to a certain extent, the RTs are a wealth of knowledge, and sometimes just going in the room and just sort of tweaking things and trying to see what makes that patient comfortable, because certainly what works for one doesn't work for another. So I think keeping an open mind, but also I think what I've tried to impress upon them is the wealth of information that is available to you, and that you're not on an island, and that particularly if you're working with an RT that's used to taking care of adults, I completely defer to them. And if they have a suggestion for what they want to try, I'm all for it. And it's either going to work or it's not. And if it works, great. And if it doesn't, then you move on to something else. So we have not put all of our patients on one particular mode, and have not used one particular weaning strategy. I think you start with what you're comfortable with and then adjust it based on how the patient responds to it. We are essentially extubating everybody to heated high flow nasal cannula, 50 liters, 100%, and then weaning from there. When they tend to fail from extubation, they fail very quickly. So it's not usually sort of hours and hours or days down the road. It's pretty immediate. And so just making sure that you have your plan for reintubation. So, in the new unit with the pediatric providers, we have anesthesia there and they have their whole protocol. They have a go bag that has all of their equipment and all of the medications in it so that they just take it into the room, because anything that goes in the room then has to be discarded. And just making sure that ahead of time they have everything that they need. We are using glide scopes for essentially every intubation, so that they can stand a little bit further away from the head and face. And the other thing too that we've tried to highlight for everybody, including for airway, is making sure that you take the time to don your PPE appropriately. And making sure that everybody on the team is appropriately attired before you go in the room. And that's true for code situations as well, like just making sure that everybody is safe and trying to protect all of the healthcare workers as much as possible.
Yeah, there's no emergency in a pandemic is like a statement that's everywhere. And so we've been very cognizant about that. Other things from an adult standpoint that I kind of forgot, I guess, is the length and size of the lines are so much bigger. So, I'm like, wow, a 20 gauge arterial line? Like I forgot those arrow kits and how painful those were to put the little wire through there. And so, it's definitely been like relearning those kind of things. So I was like, okay, so 15 on the right, 20 on the left, or 24, and then 24 in the groin. I haven't done many groin lines, it's been a while, like it's just different. And then the vessels are all calcified. So like when you look at it on ultrasound, you're like, wow, like this artery I have to really poke to get into it. And then there's a shadow effect from the calcium and you're like, this is unbelievable. So it's definitely a learning curve. We have an adult hospitalist that actually a medical hospitalist that's rounding with us in the mornings, so that like on the pediatric unit there's some help around it, because you're like, what's a NSTEMI, and like what is this EKG showing, and should I be worried about these PACs? And so I think there's a lot that it's like every single day, all the time, you realize that, wow, these are not kids.
Thank you guys so much. It's so incredibly inspiring to just listen to everything that you've learned and all that you're doing. And just thank you for taking the time to share it with all of us. I think this will be an incredible resource for pediatric surgeons and others everywhere. I just wanted to give everyone a chance to kind of make a closing comment if there's anything that you wanted to talk about that you haven't had the chance to mention, or kind of just like what's your one thing you'd recommend to people who are maybe a few weeks or days behind you in this process?
I guess I'll start, and I will say, gather your team. And that, I think, has been one of the most amazing things to watch, is the coming together of people from all different areas of the hospital to work together. I do think it's important, you have to balance experience with people who are used to working together. So the fact that I think initially some people had some reservations about a unit run by pediatric providers taking care of adults, but you have enough people who have taken care of adults and you bring in help. So you have, adult hospitalists to help you manage the medical side. but don't discount the fact that you're used to working with these people and you trust each other. And I think that's been a huge component. It is emotionally exhausting, as well as physically exhausting. I think taking care of these patients, I mean, you start from the moment you walk in for the 12 hours or however long that you're there. So I think making sure that you are taking care of the emotional and physical health of everybody who's working on that unit, and making sure that there are resources for that, and making sure that you're getting adequate sort of rest and mental health rest when you walk away, because it's exhausting and it's really stressful. And I think sort of keeping an eye on that aspect of the care for everybody who's on the unit. But it's been amazing how much people have stepped up and been willing to kind of work outside of their comfort zone and take care of this absolutely unbelievable need for critical care that I've never experienced in my medical career, and I hope to never again. But it's been pretty amazing to see how quickly, I mean, the fact that you can convert a pediatric inpatient ward into a 50-bed ICU in the matter of about a week and a half or 2 weeks, and just because that's what needed to be done. So people figured out how to do it.
Yeah, I would say my advice would be to get involved, because I was really scared. I was scared for myself. I was scared for my family. I wasn't sure I knew enough about how to take care of them. I had a lot of anxiety going into this, what's going to happen? How's it going to work? The first night I came out and I was like giddy. It was like a sense of relief. Like, gosh, I'm actually doing something now. And it's been, to me, now that I'm a few days into it, I feel better, actually. I feel less anxious. I feel less scared. I have my little, what do I do to like get home so that I don't bring it home? Like the 80 million times I wash my hands, and like, how much soap I've used. But like, I think that once you get into the routine, like, at the end of the day, as pediatric surgeons, we're doctors. And it's like, we got this. This is kind of our purview. We're used to taking care of adults. You're used to being put into situations you've never seen before. We do that every time. Like every diaphragm I do seems to be different. Every TEF is different. Like we're used to that process. We're used to being in situations that we're somewhat unfamiliar with. We're used to having an N of 3 and being okay with that. Like that's us. Like that's innate to who we are. And like you don't quite realize it until you're put into that situation, and then you're like, oh yeah, like I can figure this out. This is okay. I will be okay. And I think for all the people listening in, I would just say like, get involved and like, just go for it, because it's not as scary and it's actually more rewarding once you get going. And so if you have the opportunity and you see that there's a need in your community, I would say go for it, because anything you're doing is a skill set that they otherwise don't have.
Thank you, Samir. Marge, did you have anything else you
just wanted to thank Meghan and Samir. I learned a lot, and actually I'll impart some of the things. I'm taking notes, as you probably saw, impart some of that knowledge to our adult critical care people. I mean, there's, I think we have about 35 ICU cases, 35 to 40 ICU cases, because I missed the command control debrief, the morning one, to participate here. But this is an incredible amount of knowledge. Thank you so much. And, thank you for sharing, and please take care of yourselves.
Happy to help as other people sort of begin to navigate this. I mean, we're certainly not the experts, but we're, a couple weeks ahead, and happy to share what has worked and what hasn't worked. And we are, just two people in a very big machine taking care of these patients. So certainly available anytime.
Thank you, everybody, so much. And just stay well and stay safe and keep doing great things. Thank you.
Thank you.
Thanks, Loren.
One more question before you guys leave. I hate to be ICU geeky about this, but what CPP are you targeting?
Not checking it.
Not checking it at all? Okay. Just felt dry eyes and nose for the last, few days sort of thing?
Yeah, really.
Shooting for a negative 500 to a liter a day.
Oh, wow. Okay.
At least until they sort of hit steady state. I've tried to use some combination of just sort of gestalt, look from the doorway, what their BUN and creatinine are doing.
Okay.
But I mean, for a lot of them, we have not been routinely checking CVPs, partly because even with the triple lumen, often that's still just barely enough access.
Yeah.
So yeah, I no idea.
Must be weird to not do milligrams per kilogram, huh?
Yeah, the dosing is weird. I had a guy went into AFib with RVR yesterday. I was like, oh yeah, amio 150. Like, I mean, you're going back to the recesses of your mind, and like, you know, yeah, I mean, the sort of trifecta that we're seeing right now is older age, African American, obese, and asthma is a devastating combination. And you know, you just walk through the unit and it's just room after room after room. And it's absolutely, it's heartbreaking. I mean, it's absolutely horrible. But then I was talking with one of the nurses that had come from one of the Detroit hospitals, and she said she worked 2 shifts and quit because they're overwhelmed with patients. They don't have enough PPE. They don't have adequate support. You know, we are so blessed here just to have a gazillion doctors, RTs, nurses. And that's when you realize that you're providing a service that certainly in this area, no one else can provide. And so it's like, how do you, like Samir said, how do you not sort of step up and say, okay, I'm not totally comfortable with this, but I'm a surgeon. I can figure this out. Who else is going to do it? Right. But I mean, but we've had, you know, pulmonary anesthesia, but I certainly think there's certainly a surgical mindset, which is someone needs help. I'll figure this out. Like, there's none of this, I'm not comfortable. It's sort of like, what do you need? And I agree with him. It's been, you know, nerve wracking and sort of scary to sort of jump back in and take care of these patients. But you realize that, I mean, if the pediatricians are willing to do it, then we need to be there too. And I think we've been lucky, but yeah, I think you realize how much need there is to take care of these patients right now. Don't tell them that I forgot about them, but yeah, our pediatric surgery critical care fellows are coming up to help staff the new unit. Our PAs who are normally taking care of NICU babies are going to come up again, sort of the importance of keeping the teams together. So even though they may have never taken care of these patients, they're used to working with us and we're used to working with them. So yeah, they're going to come up and start working. Although it's interesting, we're a little bit in a steady state right now. We've not gotten a lot of transfers in the last 48 hours. And so I'm curious sort of what's going to happen for the next week in terms of how many admissions we're going to have versus now we're kind of turning into chronic vent units. And one of the things too that now we need to start thinking about is where are all these patients going to go when they don't need to be in the hospital anymore? A lot of them are now going to be on oxygen. A lot are now going to be on dialysis. They're going to need subacute nursing facilities. They're going to need, you know, LTACs. And
some of them will need trachs.
Some of them will need trachs. Yeah, that's sort of the next step. Is we've had some who've now been intubated for 3 weeks, and we're making protocols on how to do trach safely. And is it okay to trach a COVID positive patient? Do you need to swab them again and show that they're COVID negative? That's very much a moving target, but I think we do need to start thinking about, now that we at least have kind of gotten through, I think, sort of the acute surge and hopefully are at a steady state. What do we do now? And what's going to happen to these patients over the next couple of weeks and couple of months, and where are they going to go when they don't need to be in an acute hospital anymore? So I think it's encouraging that we're now starting to think about those issues.
Yeah, we have gone to mostly percutaneous trachs, and so the surgical ICU and thoracic folks are doing it as opposed to ENT, because ENT do open trachs and so more aerosolizing at the bedside, et cetera, et cetera. So interestingly, our surgeons are the airway people because they think that it's less aerosolized.
Yeah. Interesting. We have not, I don't know of any trachs that we've done yet. But there's a lot of debate, and ENT is not very enthusiastic.
No. And then the other thing that I worry about is, you usually when you do a perk trach, you do a bronch, right? A flex bronch. So you know that you're not back walling, especially with all the edema. And I'm like, well, then now you have an open airway. So, yep.
Yeah.
All uncharted waters, I guess.
Yes.
You do what you have to do. Like, what CPP? What are you talking about, Mark?
I know, yeah.
Talking about?
I mean, no x-rays, 1 ABG a day. I mean, you wean the vent for minute ventilation and for, O2 sat, right? And it's just, I mean, in some ways, I think it'll be interesting to see what happens and how, like, will our practice change? The downside is, like, there's very little physical exam anymore. But I think there is a way that you can sort of do critical care kind of with less data.
Yeah.
And I think it'll be interesting to see, I think there's a happy medium between what we used to do and what we have to do now. But it'll be interesting to see sort of how things settle out.